Ready.
Yeah, welcome to conference, second edition by Confrontiers. Dr. Ahmed N. Ghanem was educated in Egypt and qualified in 1974 in Faculty of Medicine, Mansoura University, Egypt. He spent his internship at Mansoura University hospitals. He gained all the postgraduate experience in UK, where he was promoted in posts up to the consultant level. He practiced as consultant urologist in UK, Saudi Arabia, and Egypt. During his career life, he won the award of Princess Alexandra Memorial Award and reported for having over 100 articles of which he made important discoveries, very good, in medicine, physiology, urology, nephrology, cardiovascular, and surgery. He discovered two new types of vascular shocks, proved that one physiological law is wrong, and provided the replacement of G-tube hydrodynamic. He resolved the puzzles of three clinical syndromes: the transurethral resection of prostate, TURP syndrome, the loin pain hematuria syndrome, LPHS, and the adult respiratory distress syndrome, ARDS. And he is also an editor-in-chief for Surgical Medicine Open Access Journal. His title for today's presentation is Volume Kinetic. We call it VK shocks or volumetric overload shocks, VOS, in clinical practice. Welcome, Dr. Ahmed. Please go ahead.
Thank you. Thank you very much indeed. My presentation today is about volume kinetic shocks or volumetric overload shocks, VOS, in surgical practice.
Very good. Would you like to share your PPT, sir?
Share my screen?
Yeah, please share your screen.
Okay. Can you see me now?
No.
No, not yet?
No.
I pressed share. What else can I do?
Then you can. Hope you have taken out your PPT on your desktop. Because
what do you mean? Sorry.
Because many a time when you find out from your other folder that it finds difficult. When you already taken out on your desktop, it becomes more easier to share the screen. That is what I'm saying.
The share screen is green now, but I don't know why you can't see me.
We can see you, but
can
not
you see
your
me now?
PPT. Yeah, we can see you, not your PPT.
Not my presentation?
No.
What should I do? What should I do?
So, Dr. Ahmed, would you like us to share your PPT?
Please.
Okay, thank you. Thanks a lot. Thanks a lot.
Go ahead, Mr. Krishna, please.
Yeah.
Thank you.
Shall I start now?
Let him open it.
Yeah.
You will also see it. Accordingly, you can go ahead. Yes.
Okay.
You can also see it?
Yes, yes, I can now. Thank you very much.
Yeah. Please keep on saying so. Mr. Krishna will do the needful.
Will you change the slides for me, or can I do it myself?
We will do for you.
Try. Next slide, please. No, next slide. I introduce myself, Ahmed Ghanem. We'll start with definition. What does volume kinetic or VK shocks are? Cardiovascular shocks induced by acute volume changes of the cardiovascular system in either direction by decrease or increase. A decrease in cardiovascular volume induces the well-established and well-known hypovolemic and hemorrhagic shock. Cardiovascular shocks induced by volumetric overload have recently been reported. Next slide, please. Volumetric overload shocks, those are of two types depending on the type of fluid inducing it. Sodium-free fluid induced type 1 or VOS 1, and the sodium-based fluid induced type 2 or VOS 2. Both types of VOS complicate fluid therapy in clinical practice during the resuscitation of shock, acutely ill patient, and during prolonged major surgery. VOS remains unrecognized and underestimated. Next slide, please. When it is realized that the acute dilution hyponatremia and the acute respiratory distress syndrome or ARDS is representative of each type of the two mortality, cost, and mortality. It affects hundreds of thousands of patients worldwide every year, including surgical, urological, and obstetric patients when women and children are undergoing surgery. It concerns new discoveries in physics, physiology, and medicine. The objective of this article is to bring these new discoveries into the attention of physicians, particularly surgeons and anesthetists, and this condition concerns them most. Next, please. Next, please. This figure represents several photographs in a diagram that demonstrates the hydrodynamic of the G tube, showing the magnetic field-like fluid circulation around it. Next slide, please. Next, please. There are many errors and misconceptions in fluid therapy that mislead physicians into giving too much fluid during shock resuscitation. These errors are dictated by the faulty rules in fluid therapy induced by the wrong Starling's law. These errors transfer the shock being treated, such as hemorrhagic or septic shock, into VOS, seamlessly and unnoticed when excessive crystalloids and or colloids are infused. Next, please. Next, please. Example of VOS 1 are the condition known in urology as the transurethral resection of the prostate or TURP syndrome or hyponatremic shock. The TURP syndrome is induced by massive absorption of 1.5 glycine with and or 5% glucose infusion. Hyponatremic shock is induced by excessive 5% glucose infusion. This VOS 1 occurs during or immediately after surgery, presenting to anesthetist and surgeon, and is usually mistaken for one of the known shocks of hemorrhagic or septic shocks, and gets wrongly treated with further expansion using crystalloid and or colloids. By next morning after surgery, it presents to physician with hyponatremic encephalopathy manifesting with coma, convulsion, and paralysis. Next, please. Example and the presentation of VOS 2. VOS 2 may complicate therapy of VOS 1 when excessive crystalloid and colloids are infused. It may also complicate other known shocks such as septic and hemorrhagic shock when excessive fluid are infused. It is hard to recognize in this setting and impossible to differentiate from the shock being treated. It presented later with the acute respiratory distress syndrome or the multiple organ dysfunction syndromes. Next, please. VOS are two types depending on the type of fluid inducing it. VOS 1 induced by sodium-free fluids such as 5% glucose and 1.5% glycine, used as irrigating fluid during the transurethral section of the prostate surgery. It is known in urology as the TURP syndrome or hyponatremic shock. This VOS 1 is induced by 1.5 glycine absorption and or 5% glucose infusion of about 3.5 liter to 5 liter or more than 5% of body weight, and is characterized with acute dilution hyponatremia. This VOS 1 is induced volumetric overload proved to be the most important, highly significant factor in the pathoetiology of VOS. Next, please. Hyponatremia has two nudges and two paradoxes, making it dynamic and elusive. The two nudges are the immediate drop of serum sodium level as a result of the extracellular fluid dilution that occurs during or immediately after surgery. The second nudge is that occurring later within 48 hours after water shift into intracellular compartment, causing a spontaneous elevation of serum sodium towards normal. Yet the clinical picture gets worse due to generalized cellular edema. This cellular edema manifests as the multiple organ dysfunction syndrome mods or ARDS. The two paradoxes are pathological volumetric overload induced hyponatremic shock or VOS and acute renal failure, which is paradoxical to the physiological volume replacement and treats hypotensive shock and induces diuresis. Next, please. This graph shows the volumetric gain during the TURB syndrome according to type and volume with mean and standard deviation. Next, please. This graph shows the volumetric overload in 23 case 3 patients represented as liters and the percent of body weight. The first three groups were wrongly diagnosed as one of the recognized shock and treated with further volume expansion. Group 2 were 10 patients from the series who were diagnosed as volumetric overload shock and treated with hypertonic sodium therapy. Group 3 were 10 patients who were prospectively studied and subdivided into group 3.1 of 5 patients and group 3.2 of 5 patients who were treated conservatively and with hypertonic sodium. Next slide, please. The clinical manifestation include, in addition to cardiorespiratory features, coma, acute kidney injury, and hepatic dysfunction. It also causes coagulopathy and excessive bleeding at the surgical site. VOS 1 affects women too during transcervical resection of endometrium due to 1.5% glycine absorption and cesarean section due to excessive 5% glucose infusion. Foods affect all patients as shown in table 2, but one system may predominate, such as coma in VOS 1 and ARDS in or AKI may predominate in VOS 2. Next, please. This table summarizes the cerebral, cardiovascular, respiratory, renal, and hepatic manifestation of VOS, which is identical found in ARDS syndrome. ARDS do also occur. Next, please.
Hello, Dr. Ahmed. Are you there? Hello? Hello, Dr. Ahmed. Can you see your slide? Hello? Long silence.
Can you know?
Yeah, please
Hello?
continue, sir.
Next slide, please. I shall continue.
Yeah,
Next
please
slide.
continue. Next slide, Mr. Krishna.
Yeah.
The one after. VOS is always mistaken for one of the recognized shocks, such as hemorrhagic and septic shocks, insurgically treated with volume expansion using sodium-based isotonic fluids. This is VOS2, and the cardiopulmonary arrest has no serum marker and cause ARDS in patient will survive a bit longer. Cardiac arrest or respiratory arrest in isolation or in combination of both have been reported as immediate presentation of Turp syndrome induced by 1.5% glycine and dilution hyponatremia, induced by 5% glucose during surgery as a representative of VOS1. Multiple regression analysis has proved that volumetric overload is the most significant factors in causing the clinical picture of VOS. Figure 2 and 3 and table 1 were shown. Next slide, please. Next slide, please. This shows the high significance of the fluid gain in volumetric overload shock. Next slide, please. Professor Hand studied volume in the patient. He concluded in a recent article that guidelines for fluid therapy rarely consider that adverse effects occur in a dose-dependent fashion. Adverse effects of crystalloids are related to their preferential distribution in the interstitial and subcutis, the gut and the lung. The gastrointestinal recovery time is prolonged by 2 days when more than 2 liters is administered. Infusion of 6 to 7 liters during open abdominal surgery results in poor wound healing, pulmonary edema, and pneumonia. There is also a risk amount cause organ dysfunction by breaking up the interstitial matrix, the 40%. Coagulopathy is aggravated by coexisting hypothermia, although edema can occur from both colloids and crystal pathology. Next slide, please. Next slide, please. Hello?
It is literature 3 you don't want?
Next slide, please. Yes, the one after that. Other authors also found, no, go back to 2, please. This is 3, go back to 2. Please.
This one?
Number 2, literature 2.
Yeah, this is a visible here, literature
No,
2.
the one before, please. The one before. I'll say number 3, in patient of this other trauma trials, there is no sepsis involved and it was done overactively. Other authors also found, stop in 1, please. No, go back to 2, go forward to 2. Other authors have also found significant effect of crystalloid overload. I have found only 2 studies on trauma patients. Next slide, please. Hello? In patient of this other than pediatric trauma trial, there is no sepsis involved and both were done over a period of 24 to 48 hours respectively. both detected with morbidity and mortality of ARDS. John et al. Concluded large volume cholesterol resuscitation is associated with increased mortality and longer time ventilated. Based on this data, we recommend judicious use of crystalloids in the resuscitation of trauma. The conclusion by Conzi et al. Was early administration of 5 volume crystalloid fluid greater than 6 ml per kg per day significantly correlates with complications, days in the PO, and hospital length of hospital stay. This results was done over 48 hours. The hospital should encourage surgical care provider to exercise judicious use of crystalloid and fluid administration in that room and the floor. Next slide, please. Next, please. Hello? Next slide, please. Therapy of VOS and ARDS. First, we start with prevention. No, go back to prevention, please, now. Go back to previous slide. Hello?
Is it fine?
That is it, that's it. Okay. Being a heterogenic complication of fluid therapy, both VOS and ARDS are preventable. To prevent VOS and ARDS, a limit to the maximum amount of fluid used during shock resuscitation or major surgery must be agreed upon. Thus, new guidelines are required. Surgical care provider must exercise judicious use of crystalloid infusion in the trauma bay, ICU, and the floor. Replace the loss in hemorrhagic and hypovolemic shock, but don't overdo it. If hypotension developed despite volume replacement during ICU stay, inotropic drugs, hydrocortisone, sodium, hypertonic sodium therapy should be used. The latter restores the capillary sphincter tone, peripheral resistance as well, and they make the capillary again, but no isotonic crystalloid or colloids over infusion is required. To learn the new correct science, one must unlearn the old incorrect habits. The fungal practice should be abandoned. Bolus fluid therapy in surgical patient, abandon the aggressive current liberal regime of early goal-directed therapy in treating shock septic cases. Multiple huge multi-center trials have proved it to be wrong. Please refrain from persisting to elevate CVB to levels above 12 or up to 18 and 20. This is a major cause for inducing VOS and ARDS during the shock resuscitation, particularly septic shock. Next slide, please. Next slide, please. Hello?
Is it fine?
That's fine. Therapy of VOS and ARDS, curative therapy, hypertonic sodium HSCT of 5% sodium chloride or 8.4% sodium bicarbonate is life-saving therapy for hyponatremia, the Turp Syndrome, and the ARDS type 1. It literally brings the patient back from the dead. It is worth trying early and studying in VOS 2 and ARDS. A prospective randomized trial in 100 patients is recommended to give rapid and adequate answer to the effect of hypertonic sodium in ARDS. That is a study I look forward to reading a report on. Next slide, please. Thank you very much, and I'm happy to take your question. Hello?
Thank you very much, sir.
Thank you.
For a well-explained presentation.
Thank you.
Any questions from any corner?
Thank you.
If no questions, can we move to the next one, Dr. Anjana?
Can we move or?
Can we go for a break for 5 minutes?
Yes, because Anna told me ki 10 minutes
Okay,
break.
okay. That's okay then. Fine.
Okay.
We can
So
go for a
anybody
break for 10
would
minutes.
like to have anything, because for many of them will be a lunchtime or so.
Yeah. So we can go for a break for 10 minutes, right?
Yeah.
Okay, thank you, Dr. Meena.
So we'll meet again.
After 10 minutes.